So I'll be showing you a case which we learned in a hard way. It was a patient of 67 years old, which was under chemotherapy for neuroendocrine tumor of unknown origin with liver mets, and the disease was progressing constantly. So he had generalized weakness with no neuroendocrine symptom like diarrhea, flushing, or hypertension. Physical examination was unremarkable, and AFP was normal, and the chromogranin A was raised to 456 nanogram per liter. So this is the CT scan when we received the patient. It shows multiple hyper enhancing lesions showing washout in the portal venous phase involving both the lobes, as you can see. Then in the next slide, there are multiple lesions in the left lobe even. So we thought there in the multidisciplinary meeting, it was decided to take the patient with TACE, and we decided that we will tackle both the lobes separately. So in the angiogram, we saw there was extensive tumoral blush involving the right lobe. So we were thinking to go selectively into all the lesions. Rather than that, we went directly we directly went for the lobar TACE, and it was a depth TACE. So here we can see the drug is going into the right lobe lesions, and in the third slide, we knocked all the vessels off. So there was no residual supply involving the right lobe. After an interval of the patient had slightly raised in the LFT levels, which gradually settled in an interval of 1.5 months. So we went for the next stage after 2 months, and as you can see, selectively tried to go into the vessels, then ended up doing whole lobar TACE of the left lobe as well. Okay. So while conducting the second TACE, again we went into the right artery and saw there was some little residual blush left. So we did a little top of the right lobe residual tumor as well. So after knocking off both the arteries, the patient came to us after a span of 1 month for a follow-up. He was having weight gain, appetite was improved, chromogranin A was significantly reduced from 450 to 43, and imaging also showed devascularization with up to 30% reduction of the tumor. So he was left on clinical follow-up. But in the month of September, patient again returned to us with subacute onset of unwellness, fever, and loss of appetite, for which we conducted a triphasic CT, which shows multiple hypoattenuating areas with no significant surrounding liver enhancement or any washout in the portal venous phase. Especially there was a lesion in the left lobe which was having a attenuation value of about 20 with no significant enhancement in the subsequent phases or washout. So we checked on ultrasound and it was a abscess. So we drained that abscess. Patient presently is doing well. Currently the serology report shows slight increase in chromogranin A, which is 346, still less than the baseline. So I would like to go to the literature. What was the problem in the case which we did, and why? What are the reasons of development of the abscess in case of both lobar TACE? So up to 40% of the patients with neuroendocrine tumor, when they present, they already are having liver metastasis. So surgery and medical management are one mode of therapy. Then the patient can be provided with TAE, TACE, or TARE. So these are the types. There are 3 types. They find type 1 predominantly larger lesion in the one lobe, then type 2 predominantly involving one lobe with occasional lesions in the left, and florid type is called as type 3. So ours was a type 3 tumor. Type 3 means diffuse liver metastasis, and the consensus guidelines say that the treatment modality for diffuse metastatic liver is either TACE, TAE, or TARE. As the patient was very poor, he couldn't afford TARE, then of course we went for TACE. So there the reports say that there are higher incidence of bile duct injuries with depth TACE. So that's why some hospitals find it controversial to use depth TACE in case of neuroendocrine metastasis. Why these injuries happen more? The cause is that the intrahepatic bile ducts do not have a dual blood supply as the rest of the liver, as you all know, and these are fed from the hepatic arteries and form a vascular, which is peribiliary capillary plexus. So the depth gets deposited there, and that causes bile duct injury. And over and above that, in neuroendocrine tumors, there is preferential diversion of the vascular supply into the peribiliary plexus. So that again leads to more depth deposition. And the reason behind we choosing depth rather than conventional TACE was that there is a study by Dever which shows that there is up to 80% of the radiological response if we use depth TACE. So there were a few things also in favor, few against it. So the decision of depth was taken. This I have already covered. Coming to the next. So the technique of depth TACE is slightly different from the conventional TACE. If it's a neuroendocrine tumor metastasis, considering the endpoint of the embolization, and however there is no standard recommendations for selecting the endpoint, but still it has been suggested that conservative embolization endpoint gives a better result. So what does conservative embolization endpoint means? That still there is some flow into the vessels, whereas we cannot see the tumoral blush, which is SAC2. So these are the various studies which show that the results with conservative embolization in depth are considered better. These are the parameters on which we should follow: the plasma chromogranin A, HIAA, synaptophysin. We follow chromogranin A for our follow-ups. So what's the take-home message? That with depth TACE embolization, endpoint should be arterial. In case of neuroendocrine metastasis, the endpoint should be arterial free flow circulation with tumor devascularization in neuroendocrine mets. So that's it.